Good afternoon, everyone. My name is Hagen Klieb. I'm an oral medicine and oral pathology specialist. I'm coming in from the University of Toronto, Sunnybrook Hospital, where I practice oral medicine and oral pathology. I am going to be giving you folks a refresher today on topics in oral pathology, and I'm grateful that you are giving me your time tonight. Now, a little bit about myself. As I've mentioned before, my home base is at Sunnybrook Health Sciences Center. I'm in two departments here. I'm in the Department of Dentistry, where I see patients and I partake in procedures like biopsies and diagnostic interventions. I also work in the Department of Pathology, where I, of course, work under the microscope, as evidenced by my microscope beside me. I see what I consider some of the most challenging cases, and I'm involved in cancer care in all forms. When I'm not at Sunnybrook, I have a few other areas of interest. I am the lead of the Oral Pathology Diagnostic Service at Life Labs, and I'm also a member of the CDPA, the Canadian Dental Protective Association, where I see medical legal cases and provide my opinion in this regard. Now, this again is meant to be a refresher. And as far as the area that I'd like to refresh you, I've chosen oral potentially malignant disorders, or more colloquially, I'd call this precancer. By the time we're done this topic, you should have a thorough understanding and comfort level with regards to how we define these, how we recognize these, and how we manage them. Now, I wanted to start off with some facts. And the first fact that I'd like to tell you is that oral cancer, and by extension precancer, tends to have a reputation of being rare. And I don't particularly agree with this. I would say that these conditions are maybe uncommon, but they are not rare. Looking at Ontario statistics, these are from 2020, we can see that the most common cancers in Ontario were breast cancer, lung cancer, and colorectal cancer. But not exorbitantly behind in terms of statistics, we have cancers of the oral cavity and oral pharynx. In 2020 in Ontario, there were almost 2,000 cases of oral cancers, and I would say that the bulk of these patients would have presented to their dental practitioners first, who would have got the ball rolling. So again, sometimes people are skeptical to learn about oral pathology because it's seen as an academic topic, something that you'll never see, but if you do, you have to be prepared. The second fact that I'd like to share with you is that the diagnosis of oral cancer is actually very straightforward. This photograph that I'm showing you here shows a fungating tumor on the side of the tongue. And unfortunately, by the time precancers have progressed into cancer and have developed and enlarged to this point, the diagnosis is extremely obvious. Another fact that I'd like to share with you, and I think we all inherently understand this, is that the treatment of oral cancers is very difficult. The management of these cancers is usually multimodal. I'm showing you a photograph. Unfortunately, it's a very graphic photograph on the left to my screen, which shows a large cancer resection surgery where the tumor itself is removed, as well as a large rim of normal. The cancer extends into the neck as well. This is what I'd call an extremely morbid procedure. And of course, for any cells that are left behind, further therapies are required, such as radiation therapy, chemotherapy, and now immunotherapy. The next fact I'd like to share with you is that the stage of the cancer predicts, first of all, the prognosis of the patient, as well as what sort of treatments are going to be necessary. The staging system that we use for oral cancers is the TNM staging. The T stands for how large the tumor is. The N stands for the status of the lymph nodes, and the M stands for whether or not there's distant spread to lungs or bone or other areas of the body. Now, with this system in place, we derive a stage that's either 1, 2, 3, or 4. In stage 1 and 2 is typically called early cancer. Stage 3 and 4 is advanced cancer. The photograph here shows an early cancer. This is a very small cancer that was detected on a routine dental examination. This patient will have a very favorable prognosis, and the treatment will also be fairly straightforward as well. A patient like this may be treated in an outpatient procedure clinic with a small resection, 1 centimeter around the visible margin. Obviously, there'll be a 1 or 2 weeks where the patient is recovering, but they'll recover with very good form and function. And again, importantly, their prognosis will be excellent. On the other hand, a patient like this who presents with advanced cancer, large, infiltrating the bone with mobile teeth, this patient is going to require aggressive multimodal therapy, and their prognosis is going to be quite poor. Moving on with my facts, the most disturbing fact is that most oral cancers that we see are stage 3 and stage 4. And this is a bit of a paradox in that the mouth is so easily accessible, we can all view it. However, most cancers, and I would estimate maybe 60 to 70% of cancers, will present initially with a large stage 3 or stage 4 cancer. The photograph that I show here shows a large fungating mass on the palate, which is fairly what I would call par for the course, unfortunately. Now, I'm almost done with my facts, but fact number 6 is that oral cancers almost always are preceded by a precancerous lesion. This is illustrated here where we have the same patient separated by 5 years. In 2012, on the palate, what we have is a fairly innocent appearing reddish area. It looks very innocent. It may be confused for a burn, but in any case, time goes on, and by 2017, we have a very advanced cancer. So in retrospect, this lesion in 2012 is actually a precancerous lesion. I would call this an erythroplakia. The 7th fact I'd like to leave with you is that the detection and management of oral precancerous lesions, if done properly, will improve our patients' morbidity and mortality. What I mean by this is that if I would have seen this patient early on when they had the precancerous lesion, I would have excised this area, I would have put them into strict follow-up, and I would have expected them to lead a very long and full life in a perfect world. On the other hand, by the time the patient is presenting to us 5 years later with advanced cancer, their prognosis is poor and the treatment that they require is large and difficult. The 8th and last fact, thank you for your patience with all these facts, which I know can be a bit annoying, is that missing these precancerous lesions has huge ramifications. Most importantly, the ramifications reflect our patient's well-being. The larger the cancer, the more aggressive the treatment, the poorer the prognosis. And also, as unpleasant it is to bring up, there are medical legal ramifications. In my capacity as a medical legal advisor, cases of missed oral cancers are fairly common. So, what I'd like to discuss with you today is again a refresher on oral potentially malignant disorders or precancers. Now, again, what precancers mean in a very sort of basic fashion here is it's a group of morphologically altered tissue that has an increased risk of malignancy. And what I tend to think of them is landmines. Things that may not affect you today or tomorrow, but given enough time, may progress into something dangerous. The unfortunate reality is that the vast majority of patients that I see for oral precancerous conditions do not present with any symptoms. They do not present with pain or bleeding, things that make us aware of them. These are lesions that are found usually on routine examinations. For example, a patient presenting to you complaining that they're not satisfied with the aesthetics of tooth 1-1. In other words, patients will not bring these to your attention. You need to look for these, hence why we're doing this course tonight. Now, oral potentially malignant disorders, precancers, is a very large group of disorders. And I tend to think of these a little bit in the realm of academic lesions, things that we teach to dental students, to medical students, things that come across once in a blue moon. And then there are the real life conditions, things that come across your dental practice on a fairly regular basis, things that you're more likely to see. As an example of a precancerous condition that I'd consider to be rare or historic, I have an example here of a patient who presents with a white lesion on the maxillary gingiva. And in this case, this was caused by a toothpaste that contained something called sanguinaria. There was a time many moons back when we were seeing patients with these sort of precancerous lesions until we recognized the causative agent, this sanguinaria in Viadent toothpaste, and it has since been discontinued, and it exists as a footnote in the annals of history. Similarly, patients with syphilis at some point in the distant past were more likely to develop oral cancers and precancers. Why exactly this was, we're not exactly sure, although the going theory is that these patients would treat the oral lesions of syphilis with arsenic concoctions. I'm showing a picture of one here, and we think that the arsenic exposure probably predisposed these patients to oral precancer and cancer. We would call these syphilitic leukoplakias that could progress into cancers. Again, I mention this just for interest and historically. There are some conditions that may not be historic. These are contemporary, but I mention really out of interest and to complete the course here. And also out of interest as well. I have a small group in my practice who smoke cigarettes, but rather unusually, they smoke with the lit end of the cigarette inside their mouth. This is a very peculiar way of smoking. I don't particularly recommend it. Some studies have investigated why an individual would do this. It tends to be found more commonly in an individual whose mother did this. So maybe there's some mimicry. And for whatever reason, it's found more commonly in cold climates. I wish I could tell you more. It's an unusual, bizarre way of smoking. And what's interesting about this, and I'd say more tragic about this, is that it is associated with precancerous lesions on the palate and a high proclivity for cancer. So the take home there is, A, don't smoke cigarettes, and if you are going to smoke, lit end out. Historically, certain malnutrition conditions can also predispose an individual to precancers and cancers. This is a patient with Plummer-Vinson syndrome. Plummer-Vinson syndrome is a condition that we typically see in Northern Europe in individuals who are chronic iron deficient. And in these individuals, they complain of difficulty swallowing. We see changes in their nails, their spooning of the nails. And in the mouth, the tongues appear smooth and atrophic, as we see illustrated in this photograph here. The significance is in these patients with chronic iron deficiency, they are more inclined to develop precancerous and cancerous lesions. I've only encountered a patient with Plummer-Vinson syndrome once in my career, and that was during my fellowship specialty examination. I've actually never seen it in real-life practice. Now, moving on, there are some localized oral lesions, all very uncommon, that can also be predisposing factors to oral cancers. I've listed them here, and I'm illustrating one of them here as well. This is a verruciform xanthoma. A verruciform xanthoma is pretty darn uncommon. In my practice, where I see oral pathology patients 5 days a week, almost 360 days a year practically, I'll see maybe 1 or 2 verruciform xanthomas annually. These yellowish warty-like lesions can sometimes be confused as warts or verruca vulgaris, but rather if you were to biopsy this under the microscope, you would see that they're filled with xanthoma cells, which means histiocytes or macrophages filled with cholesterol. So that's what xanthoma means. It means cholesterol-laden cells. Now, I don't want to get too much into verruciform xanthomas because, again, they're quite uncommon, but there have been studies associated with verruciform xanthomas degenerating over time into cancers. So it's one thing that when I see a verruciform xanthoma clinically or under the microscope, I will put a patient into long-term surveillance. But again, my point is that these are uncommon, and I mention them for completeness sake, but it's not something that you're likely to see your first day back in practice on Monday. What about genetic predisposition? Sometimes I'll have a patient who tells me their mom or their dad had oral cancer and they're worried about oral cancer themselves. Fortunately, I don't see much of a family predisposition or a family clustering of oral cancers, although that's not to say it can't happen. There are some genetic conditions, and I've listed them here, that are very well known to be associated with oral cancer. This is an interesting article that was in the Globe and Mail, or sorry, it was on Global News, that showed a city in Brazil that was described as villagers who would melt in the sunlight. And this is a photograph that nicely shows one of the children of this village that would not go anywhere else in town without sun protection. This village has a clustering of a genetic condition called xeroderma pigmentosum. These individuals have a defect in their DNA repair gene, and they are prone to hundreds, if not thousands, of oral cancers on any part of the skin that's exposed to sunlight. These individuals obviously have a much shorter survival. You can see one of the patients here whose skin is just riddled with basal cell carcinomas, melanomas, and squamous cell carcinomas. This poor child has had to have his eyeball removed, his nose removed, and even the small amounts of sunlight that is exposed to his tongue led him to develop oral cancer. In my practice, I have only 2 patients with this rare genetic condition. And again, it's one of these conditions where almost universally they will succumb to skin malignancies. Fortunately, thank goodness, it's not common. Now, I've just gone through the gamut of some very uncommon or historical precancerous conditions. Obviously, I mention these out of interest, but what I really wanted to discuss with you folks today is not so much interesting topics, although I hope my lecture is interesting, but the crux of it is things that are likely to encounter throughout the course of your career. And I've listed the precancerous conditions that I'd like to discuss because these are the things that I see regularly, and my patients come from your practice. Now, before we talk about these precancerous conditions, let's talk about how we find them. And this sounds very basic, but this is an often cited source of confusion. Certain cancers, breast cancer, colon cancer, are screened. We all know that certain individuals need to go, almost all individuals need to go for screening mammograms, screening colonoscopies. As far as screening for oral cancer, this primary screening, this is something that is not done. It's something that just hasn't panned out. It is not cost effective. So what we do in lieu of this is opportunistic screening. These are patients who present to their dentist, who can have an examination, and if there's any abnormalities, they can be referred for further assessment. Quite simply, the gold standard for detecting oral precancerous and cancerous conditions is what I would call a comprehensive head and neck examination. I perform this exam every day when I see patients. In an average oral pathology practice, in an average day of mine, I'll see approximately 50 to 70 patients a day, and every one of these patients gets a comprehensive head and neck examination. I can do it very quickly. It usually takes me maybe anywhere between 4 to 7 minutes with some variation. It's something I can almost do by reflex just because it's something I do so often. There's no special tools that are required, really a good light, some gauze, a few mirrors. I always start off my examination with an extraoral exam. Using bimanual palpation, I will palpate the saliva glands, the temporomandibular joints, and most importantly, the lymph nodes of the neck. And I'm illustrating an example of such an exam here. This diagram here illustrates the lymph node chains of the head and neck. And what I typically will do in my exam is I'll start off in the submental area, palpate using the fleshy pads of my finger, palpate towards the parotid area in the ear, down the neck, and then finishing at the supraclavicular area. I feel the right, the left side of the neck, and what I'm feeling for is really any sort of enlarged lymph nodes, anything that almost feels like a marble underneath the skin. Things that get me concerned is if I feel something that's more than 1 to 1.5 centimeters, firm and fixed. That would require further assessment. Once the extraoral exam is complete, all tissues of the mouth need to be visualized, and they should ideally be palpated if possible and practical. Again, to perform this part of my examination, I use some gauze, I use some mirrors, I'll retract the cheeks, I'll retract the tongue, push the tongue, and again, I will visualize and ideally palpate all the surfaces of the mouth. Now, a very common question I get is, should I use diagnostic adjuncts? And there are many. There's autofluorescence studies, chemoluminescence studies. You may recognize them by their names like Veloscope or Visalite. There's many. And what I generally say is that you are right to use these, you are right not to use these. They have pros and cons, and it's up to you whether or not you would like to use these. Now, there are advantages of using them. Number one is, quite simply, some patients, and many patients, feel that their dentist truly cares and is looking for cancer. It provides patients with reassurance. Another advantage of these systems is that they have a high sensitivity. If there's a lesion, and for example, in this picture here, I'm showing you an erythroplakia, a precancerous lesion on the palate, but if there's a lesion, almost always it'll be picked up. The other thing that's kind of nice about these systems is they give us much better lesional characteristics. So you can see in the photograph on the left where we're using just an overhead light, there's a red area. It's hard to see. But in the Veloscope examination, where lesional tissue appears dark, it loses its normal greenish hue, we can much better identify the lesion edges and take an accurate measurement. So again, there are advantages of using these diagnostic adjuncts, but there are also downsides. One of the main downsides is the sensitivity. And what that means is, while it picks up cancers, it also picks up things that are not cancer. In this case, again, we're using Veloscope, and there is an area of loss of fluorescence, a dark area on the cheek, that one would assume could be precancer or cancer, but when the lights are turned on, we see these typical lacy stria that are indicative of oral lichen planus. And unfortunately, these false positives can give rise to unnecessary biopsies and a great deal of patient anxiety as well. So again, I would say that you are right to use these, you are right not to use these. The key thing is they do not replace a comprehensive head and neck examination. Now, with that sort of introduction, I'd like to jump into these precancerous lesions and give you an oral pathologist's approach. The first precancerous lesion I'd like to talk about is one that we often omit to even consider. The patient sits in our chair and we look directly into their mouth. But what about lesions on the lip? And actinic cheilitis, which means sun-damaged lips, are very commonly encountered in my own experience. Actinic cheilitis is sometimes called farmer's lip or sailor's lip because we tend to see this more commonly in professions who are outside, in the sun's rays all day long, 20-hour days and what have you. This is a picture that I took from social media, probably Facebook or a similar site, and I thought it was interesting because it shows the ravages of sun over time. This individual is a trucker. He sits in his truck, driving long hours, and the left side of his face is exposed to much more sunlight than the right side of his face, and we see the changes over time that sunlight has. Similarly, UV exposure, chronic, can expose us to danger of or to precancerous changes on the lip. Because of the physics, the way the light hits the face, these damaging effects are much, much more likely to affect the lower lip than the upper lip. In fact, I don't remember the last time I've seen cancer of the upper lip. So really when we're talking about lip cancer, we're talking about lower lip lesions. We tend to see lip cancers and precancers in individuals who are fair-skinned. We tend to see these in adults, at least over the age of 45, because they've been exposed to sunlight for so many years. And we tend to see them much, much more commonly in males. There's many reasons for this. Perhaps males are more likely to be involved in recreational activities like golfing. That's not always the case. Males are much less likely to use cosmetic products like lipsticks that have UV protective factor in it. So one thing to bear in mind is demographics, much more commonly in males, and again, over the age of 45 or 50. When the lips have been chronically damaged by UV rays, we call that actinic cheilitis. And like any disorder, actinic cheilitis exists on a spectrum. Here I'm showing you a patient with early actinic colitis, which to be frank is extremely common. I'd say most of my patients who are 40 or 50 will have some degree of actinic colitis, and this is not an inherently dangerous condition. Signs of early actinic colitis relate to a blurring of the vermilion border. So what this means is that the nice crisp border between the skin and the lip has been lost. And also what we'll see is what I call atrophy or a blotchiness of the lip. Now, again, this type of early actinic colitis is very common. And again, it does not typically harbor high-grade precancerous or cancerous changes. Now, with time, as the actinic colitis is allowed to progress, we can develop an advanced case of this, whereby there is diffuse crusting, scaling, and ulceration across the lower lip. It's quite amazing sometimes how patients can be completely unaware of this, perhaps because the changes are so slow and over such an extended period of time. The changes can sometimes be quite extensive. The problem with actinic colitis, whether it be usually moderate or advanced, is that it can predispose individuals to malignant transformation. And we see that here. In this case, this is a female. I think she's about 65 or 70. We can see the signs of actinic colitis. She has blurring of the lip vermilion. In this case, she developed a focal area of scaling on the lower left lip. And over time, it developed exophytic change into a fulminant lip squamous cell carcinoma. When patients have lip squamous cell carcinoma, it of course requires intervention. And if the changes are localized, as is in the case here, usually a wedge resection of the lip is done. What happens in this wedge resection is almost like a pizza slice is taken out of the lower lip, and the right and the left side are sewed together. And this creates a tumor-free surgical site, but it does create some prominent scarring. For that reason, there are some different types of surgeries that can be performed. A surgery like this may on face value look much more invasive and complicated, but these sort of surgeries are there to produce less scarring while removing the cancer en bloc. Lip cancers, if allowed to grow, will grow. They can be quite extensive, as we see in this case here, and the treatment will necessarily be much more aggressive. A patient with a very large cancerous growth like this on the lip will require an extensive resection, and this tissue will have to be rebuilt using a free flap. The free flap means that we're harvesting tissue in another part of the body. In this case, this was harvested from the radial forearm, and this is used to replace the tissue that is excised. Now, obviously, this is not advantageous. We would much rather diagnose lip cancers earlier on, or ideally in the precancerous phase, and minimize the morbidity and mortality of treatment. Again, this sort of clinical scenario, a patient with mild or early actinic colitis, is fairly common. I usually don't take a biopsy in this sort of state here. What I may do, however, is I will make the patient aware of it, and I'll recommend both long-term surveillance and sun protective behaviors. So this may involve a wide-brimmed hat, and it will usually involve a lip balm with an SPF of at least 30. I'll usually see the patient back in 6 to 9 month intervals, and I'll ask the physician or the dentist to monitor as well and return the patient should there be any morphologic or symptomatic changes. Now, in a patient like this who presents with actinic change and now there's chronic ulceration and scaling, I will obtain a biopsy. Now, I don't want to bore you folks too much with histologic pictures, but the biopsy in this patient showed dysplasia, which is a measure of how ugly the cells are, and in this case, it was severe dysplasia. So this did require further intervention to remove any residual precancerous cells. In this case here, I could have done a wedge resection. In this case, however, we used liquid nitrogen to ablate any of the residual precancerous cells. Where the management of actinic colitis becomes a little bit more dicey and challenging is when patients have precancerous changes that are extensive across the lip. Obviously, the whole lip must be treated. Conventionally, this sort of change is managed with surgery, and this is the famous vermilionectomy or lip shave. What's done in this sort of procedure is that the entire lower lip is surgically excised. The labial mucosa intraorally is brought forward to create a substitute lip. You can imagine this is quite a morbid procedure, and oftentimes patients will complain afterwards of aesthetic defects and tightness. So there have been some developments in some alternative therapies. So for example, topical chemotherapy. This is 5-fluorouracil, which is a cream that we apply to the lip over usually a few weeks. This causes a chemical breakdown of the lip, and then it granulates in and should heal more normally. Another option would be to use a laser, and this is illustrated here, and you can see that there's pretty good aesthetic and functional results with this sort of laser therapy. The key take-home with actinic colitis is we need to inspect the lip. If there are signs of UV exposure, we have to make the patients aware of this. Preventative measures are prudent, such as UV protection and monitoring. And if there's any more extensive changes, such as ulceration or crusting, this should be biopsied or referred. Now, moving on topics, I'd like to switch to autoimmune diseases, which dentists will very commonly encounter. And this will be explained in a second. But these autoimmune diseases are thought to predispose individuals to cancerous changes as well. Now, the autoimmune disease that is thought to be predisposing individuals to precancers and cancers are what a group of conditions that we call a lichenoid mucositis. Quite simply, a lichenoid mucositis is characterized by a band of lymphocytes beneath the epithelium. And we see this most classically in oral lichen planus, but also in other conditions like lupus and graft versus host disease. Now, these latter two conditions are fairly uncommon, but oral lichen planus is extremely common. Usually when I ask my colleagues who here has a patient with lichen planus in their practice, usually about 95 to almost 100% of individuals will raise their hand. Now, for a condition that we encounter so commonly, very little is known about lichen planus, and there's many misconceptions. This rather confusing photograph here shows a breakdown on the molecular idiopathogenesis of lichen planus. But quite simply, what's happening here is that our body's immune system is recognizing the epithelium as foreign. The epithelium must be exposing some sort of antigen that the immune system recognizes as foreign, and the immune system attacks. And that attack gives rise to the characteristic lesions and symptoms of lichen planus. Now, again, I've listed the different autoimmune diseases here that are associated with oral cancers, but because the other two are so infrequently encountered, I'd really like to concentrate on lichen planus. Lichen planus is a skin condition, first and foremost. Here I'm showing you some very characteristic lesions of lichen planus. Classically, the flexor surface of the arm is affected by these itchy purple papules. On the other side here, I'm showing you a process called Koebner phenomenon, which means lesions of lichen planus are exacerbated by physical irritation. In this case, I think many of you who are astute would recognize that the patient was wearing a Band-Aid, and that Band-Aid flared up the lichen planus. We see this sort of Koebner phenomenon in the mouth, and that is when there are jagged restorations or xerostomia, symptoms of lichen planus will be exacerbated. Lichen planus can affect any mucocutaneous surface. In this case, I'm showing scalp lesions that can present with focal areas of balding. This can be quite distressing for our patients, and what I'll often do in this sort of situation is I'll refer to a dermatologist, because this can respond to intralesional steroid injections directly into the scalp. Now, again, all of us have seen these sort of lesions here. This is a patient who presents with lesions at both the right and left side of the mouth, presenting as lacy white stria. We call these Wickham stria. And this is the reticular variant of lichen planus that we're all used to seeing. Sometimes This chronic inflammation, especially in dark-skinned individuals, can give rise to exorbitant pigmentation. And sometimes this pigmentation can evoke consideration of other malignancies such as melanoma. This is obviously not the case. Now, looking at this picture here, what we see is a brown patch on the buccal mucosa, but if you look very carefully at the periphery, you can see the classic Wickham stria. So this is reticular lichen planus with post-inflammatory melanosis or pigmentation. Has no clinical bearing. It's not significant in any way as far as treatment or diagnosis, but I just want to make you aware of the variety of presentations. There are different subtypes of lichen planus. On the left, I have a patient with diffuse gingival erythema. This is the atrophic variant, characterized by red lesions. And on the right, there are open sores, there are ulcers. This is the erosive variant of lichen planus. How do I diagnose lichen planus? Almost always, this will be clinical. Sometimes a dentist will contact me saying, "You didn't take a biopsy. How do we know it's lichen planus?" And the way I'll usually respond is, I'm satisfied with the clinical appearance. The typical lacy white stria on the right, on the left side of the mouth, a mirror image. That is satisfactory to me. Now, with that being said, a subset of my patients with lichen planus I will biopsy. I'm illustrating a patient I biopsied here, and what we can see is there is maybe some lacy striated keratosis, but it is primarily erythematous. And on the picture on the right, I can peel off the epithelium with a periodontal probe. This is called Nikolsky sign. So in a case like this, I would biopsy to confirm that it's lichen planus and to ensure that it's not another mucocutaneous condition such as mucous membrane pemphigoid or pemphigus vulgaris, other skin conditions. The way that I confirm the diagnosis, of course, is with a biopsy. And it's not a single biopsy, but rather two biopsies. One of the biopsies I submit in formalin, and I'll look for the characteristic features of lichen planus, again, the band of lymphocytes underneath the epithelium. And I'll also submit another biopsy for Michel solution, and that's for a procedure called direct immunofluorescence. And that is to confirm that it's lichen planus and not mucous membrane pemphigoid or pemphigus vulgaris. Now, if in your practice you perform biopsies, I commend you. I think it's fun and challenging and helpful for our patients. You will almost certainly have formalin if that's the case. If you are trying to confirm lichen planus and exclude those other skin conditions, again, you will need the Michel solution. And what I'd suggest is you contact me and I'll have my lab send you that special fixative. Again, I'm at Life Labs where I see biopsies from dentists in our community. Now, going back to our classic patient with Wickham stria at the right and left buccal mucosa, this is a very common clinical scenario, and sometimes it may be managed inappropriately. So for example, a patient like this who has absolutely no symptoms in the world, completely comfortable, the dentist may be prescribing corticosteroids. And I often tell dentists that this doesn't make the most sense to me because the patient is asymptomatic and they're going to have these lesions lifelong. So in these sort of scenario, no treatment is recommended. I usually just provide the patient with reassurance. This is what it is, and I may see the patient back in 6-month intervals. On the other hand, a patient like this with erosive lesions, these patients will be uncomfortable. They'll often describe sensitivity with spicy foods, but even lingering sensitivity as well. If they go for a walk, if they're resting, watching TV, the mouth is uncomfortable. These are the sorts of patients who do require therapy. My philosophy, or my approach to treating patients with lichen planus, is the first thing I try to do is I try to eliminate local irritation. I told you before that with Koebner phenomenon, symptoms of lichen planus are exacerbated if there is any physical trauma. So if there are jagged restorations, I'll reach out to the general dentist and ask you to polish these restorations or replace these restorations. If the mouth is dry, I will advise saliva substitutes. And then I'll reassess and see how much discomfort we're still left with. First-line therapy for these patients that warrant therapy, in other words, lingering symptoms, will be corticosteroids. There are a myriad of different corticosteroids that are used. There's creams, there's rinses, there's injectables. I'll usually start with a cream or an ointment or a gel. The most common one that we use by far is Oracort. I've shown, there's a picture of Oracort here, otherwise known as triamcinolone. And one of the downsides of Oracort is that it's very thick and goopy. So if the patient has widespread oral lesions, it's probably not the appropriate medication. In this case, I would usually use a rinse in lieu. The rinse that you use, there are many. For example, prednisolone rinse and spit. You can use a magic mouthwash. If you're not sure, you can email me or call me, and I'm happy to walk you through my algorithm for management of patients with lichen planus. For some patients who are not able to apply these medications, or if the medication's not effective, I will inject triamcinolone directly into the lesions and sometimes repeat this every 6 months or so. There is a subset of patients who do not respond to first-line corticosteroid therapy. In this case, I'll use second-line medications such as calcineurin inhibitors, which is tacrolimus. Tacrolimus is a cream. It looks just like a steroid. They apply it on the area, but it works as an anti-inflammatory using an alternative pathway. The downside with using a medication like tacrolimus is it's expensive. One tube will be about $300. And there have been reports of tacrolimus predisposing individuals to oral cancers and oral lymphomas. In some patients who are just miserable, nothing is working, and especially if they have widespread lesions, I will use some systemic interventions. There are no gold standards for what medications to use first, but oftentimes this may be a short course of prednisone, although I'm less inclined to do this in the midst of a pandemic. Other medications that I'll use will be the retinoids. I'm currently doing a clinical trial using apremilast, which is a medication that we would typically use for psoriasis. Now, please know that that's not currently the gold standard of treatment. It's in investigations, and you'll need to stay tuned to know if that actually works. Now, the million-dollar question, is lichen planus precancerous? And the answer is it depends who you ask. But if you look at the bulk of studies, and if you look at the meta-analysis, there is a small risk of malignant transformation. Now, I must admit, I am a little bit skeptical. I personally think that some of the cases of lichen planus that have converted into carcinoma may have been erroneous. I'm showing you a picture here of a biopsy that was done that shows severe dysplasia or severe precancer, and underneath that there's a band of lymphocytes. And I think that in this case, an inexperienced pathologist or a pathologist not used to working in the mouth may have, almost as a reflex, called this lichen planus. This was never lichen planus. This was precancer masquerading as precancer. So again, these sort of cases like this make me skeptical. But other patients, like this fella here, make me double think whether or not lichen planus are truly precancerous. This patient here, you can recognize on the tongue dorsum, presents with a classic lacy stria of lichen planus, but there are not one but two foci of malignant transformation on the palate, manifesting as keratotic masses. These were in fact biopsied that showed high-grade precancer and cancer. So patients like this reinforce that lichen planus may in fact be precancerous, but even if that's the case, the risk is low. It's probably about a 1 to 2 to 3% risk. And what we think is that this risk primarily pertains to the erosive subtype of lichen planus. In other words, the more run-of-the-mill reticular form of lichen planus that we all see probably once a day, these patients probably don't have a risk of precancer or cancerous transformation. It's the erosive lichen planus that are more problematic. And there are some studies that say that if you tack on top of that erosive lichen planus in a smoker, in a patient who has excessive alcohol intake, or has been exposed to hepatitis C, the risk may be even higher. In my patient population of patients with erosive lichen planus who've transformed into cancer, I tend to find this cancer behaves much more aggressively, and this is supported by the literature as well. So, my approach to patients with lichen planus is I tend not to overly worry the patients. I explain to patients with erosive lichen planus that the literature suggests there may be a small risk of malignant transformation. I tend to see these patients back perhaps every 6 months. And when I see the patients back in 6 months, I survey to make sure that their condition is well controlled as far as symptoms, but I'll also perform a comprehensive exam to see if there's anything concerning, any area that may need a biopsy. And the areas that I tend to biopsy are areas that have atypical symptoms. What I mean by that is, let's imagine only one part of the mouth is bothering them. That's unusual, and I'll biopsy that area to make sure I'm not missing anything. I'll also biopsy any localized, what I call ugly duckling areas, areas that look different. So for example, a solitary area of erythema, an area that's friable, that bleeds easily, and certainly if there's any exophytic change, that requires a biopsy as well. Fortunately, in my very large practice with a very large component of lichen planus, again, I tend to see this malignant transformation infrequently. I would say the bulk of my attention to these patients is really given to symptomatic measures, but at the back of my mind, I'm always looking for signs of malignant transformation.